is there?
Madam
I'm
ache, madam
here.
ache.
Oh,
I'm
madam.
here.
Where is
Okay.
Suman Thapa? Yes, Suman Thapa is
Mijan.
here.
Madam,
Where is-
Assalamualaikum.
We are live now.
ওয়ালাইকুম সালাম মিজান
কেমন আছেন ম্যাডাম? ভালো?
ভালো আছি ভালো
Where is
আছি
Professor?
Yeah.
We are live now.
Yes, Suman Thapa is now live, and we have taken
Yeah.
our group photo. Okay,
Yes.
recorded. Now we can start. Shams Muhammad Noman, you start.
So the slide is visible, sir?
Yes.
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 No, this slide is your presentation.
No, sir. It's for the introduction, sir.
Oh, okay,
for
fine.
না
Okay, fine.
So with the thank you everybody. With the permission of our president, Professor Sharfuddin Ahmed, I'm going to start my presentation or introduction about the speakers, and the topics of today is glaucoma management, hope behind the curtain. It is organized by Bangladesh Ophthalmic Research Forum with the great supervision of Ophthalmological Society of Bangladesh.
Okay, Noman.
Yes. So just just wait, sir.
Any problem,
Okay.
Noman?
Yes, sir.
Now
you
it is
see,
audible.
see the slide?
Yes.
You'll have to share. You have to share the screen first.
Yes, yes.
Yes, it is visible now.
But it is not changing.
রাইট অ্যারোতে একটু ইয়ে দাও, রাইট অ্যারো ক্লিক করো। এখানে একটা ইয়ে আছে দেখো, ওই যে
Sir, just
জাস্ট ওভার দ্য স্লাইড দ্যার ইজ অ্যারো, রাইট অ্যারো, জাস্ট ওভার দ্য স্লাইড ইন দ্য বটম. You go to the slide,
just,
and
just,
in the bottom left you will find some arrow. Click
Sir.
that arrow.
Okay, you can continue with this. Yes. Yeah.
So, sorry for the interruption. So, hope behind the curtain. What is the meaning of hope? Actually, this is a hope for the glaucoma appropriate screening, methodical trabeculectomy, modification of filtration surgery, and complication management and tube implant. And this is a great association between the SERGs, and we congratulate all the speakers to join here. And this is our flyer, and thank you everybody to choose it and for your expert opinion about the flyer making. And the first, I want to introduce our host and chairman, Professor Mohammad Sharfuddin Ahmed, Professor and Chairman, Department of Community Ophthalmology, Bangabandhu Sheikh Mujib Medical University. He is the President of Ophthalmological Society of Bangladesh. He is the President of Bangladesh Community Ophthalmological Society, President Oculoplastic Society of Bangladesh, is the past Secretary General of Bangladesh Medical Association, is the past Pro-VC of Bangabandhu Sheikh Mujib Medical University, is the President of Bangladesh Ophthalmic Research Forum. And let me introduce our guest of honor, our motherly Professor Abha Hussain, is the Director cum Chief Consultant of OSB Eye Hospital, is the President-elect Asia Pacific Academy of Ophthalmology, Is the past president of SARC Academy of Ophthalmology, past president of Ophthalmological Society of Bangladesh, is the founder president of Bangladesh Community Ophthalmological Society. Our respected panelist, my teacher, Professor Muhammad Nazrul Islam, Chairman, Glaucoma Faculty, Bangladesh Eye Hospital, past president, Bangladesh Glaucoma Society, president, Bangladesh Society for the Cataract and Refractive Surgery, and is the council member of Asia Pacific Glaucoma Society. Our another panelist, Professor Muhammad Mizanur Rahman, Professor and Head, Department of Ophthalmology, Bangladesh Medical College, President, Bangladesh Glaucoma Society, President, International Society for Manual Small Incision Cataracts Surgery, Bangladesh chapter. And I'm really delighted to introduce Professor Nadim Hafiz Bhatt as a panelist and a speaker. He is the Professor of Ophthalmology, Allama Iqbal Medical College, Lahore, Pakistan. He is the President of Ophthalmological Society of Pakistan, past President of SARC Academy of Ophthalmology, past President, Pakistan Glaucoma Society, and Council Member, APAO and AACO. Professor Suman Thapa as a speaker. Welcome, Professor Suman Thapa. He is Director of Research, Head of Glaucoma, Tilganga Institute of Ophthalmology, Kathmandu, Nepal. Here is our another speaker, Dr. Bipul Kumar Sharkar. He is the consultant and assistant professor Glaucoma, Ispahani Islamia Eye Institute and Hospital. He is the publication secretary, Bangladesh Glaucoma Society. And let me introduce my friend, Dr. Amit Parwal. He is head Glaucoma Service, Chaitram Netralaya, Indore, and member secretary, member scientific committee, All India Ophthalmological Society. He is recently elected. Congratulations. And he is also Central Zone Executive Member of Glaucoma Society of India. And this is me, Dr. Shams Mahmoud Numan. I'm a senior consultant, head of the Glaucoma, Chittagong Eye Infirmary and Training Complex. I'm the member secretary of Bangladesh Ophthalmic Research Forum, general secretary, OSB Chittagong, and council member, SARC Academy of Ophthalmology. This is our different presentations. First speaker will be Professor Suman Thapa, then Professor Nadim Hafiz Bhatt, then Bipul Kumar Sharkar, then Dr. Amit Parwal, and me. So I am starting our program with a little speech from our guest of honor, Professor Abba Hussain. I am requesting Professor Abba Hussain to start the program with his valuable speech.
Good evening. It is a great pleasure and honor for me to be here today and address this webinar, Glaucoma Management, Hope Behind the Curtain. I'd like to extend my heartfelt thanks to Professor Shafuddin Ahmed, my beloved student and President OSB, for inviting me as guest of honor. I'm really so happy to see Professor Nadim Hafiz Bhatt, who is a very good friend of mine for more than a decade. And I can still remember the first day when we met each other in Hyderabad in a award giving ceremony, as because both of we are having the award from India, that is Indian Alumni Group of ICH London, by Dr. Shapon Shamanto, right, in 2007. So from that is the beginning of Professor Nadim Hafiz Bhatt, and then onwards we are very close each other in every conference, every congress and others.
Thank you very much, madam.
He is also the panelist and the speaker. So we will learn a lot of things from Professor Nadim and the other two panelists, Professor Nozrul Islam and Professor Mizanur Rahman, my dearest two students, and they are doing so well in glaucoma in this country. So we will hear from them later on. Next, Dr. Shumon Thapa. Shumon Thapa is the great leader as because how he has organized the Sark Academy of Ophthalmology conference in 2018. We have already seen it and believe that he will be a very good speaker and he will also a very good leader. So we will hear from him in this webinar.
Thank you, ma'am.
You're welcome. And next is the Dr. Bipul Sarkar. Really, he is the rising star in glaucoma in Bangladesh. He's doing very well. He is also a speaker, and the two moderator and the speaker, Dr. Noman and Dr. Amit Porwell. Very much they have their innovative and creative thinking, both of them. So wish that they will do very good presentation here. And I would like to thank the organizer, the ophthalmic, that is the research forum, for arranging this subspecialty glaucoma, as because this is very important subspecialty in ophthalmology. And glaucoma, we know, everybody we know that glaucoma is a blinding cause of disease. So this is not the curable disease, this is a preventable disease. So before further damage, we should very careful, and all of you are the glaucoma specialist and you should know much more better than the other ophthalmologists. So as this is also asymptomatic and the silent killer, so we should be very much careful about glaucoma. And thanks to the organizer again that this has you have selected this glaucoma as a webinar. I can just share with you one thing. In 1981, when I was resident and my mentor, Professor A.Q.S.M. Harun, I don't know how many of you know, he was the pioneer of microsurgery in Bangladesh, and he was in UK for almost 18 years. After that, he came here and started microsurgery in Bangladesh. And I was his resident, assistant registrar, while two patients were side by side in a ward that is cataract and glaucoma. And that glaucoma is very advanced glaucoma. Cataract is also advanced cataract. Both were in side by side grade, and they are talking that you can't see and I can see. Tomorrow, both of we have the surgery, and after that we can see again. So what has happened after the surgery? Next day, surgery was very good. At that time, there was intracapsular cataract extraction and a very good surgery. Professor Harun did that surgery, and also trabeculectomy in the glaucoma patient and the cataract patient, intracapsular cataract extraction, no intraocular lens implantation. But the cataract patient can see at least 1 feet, 2 feet like that. But the glaucoma patient, as because that is the advanced glaucoma, and after surgery it has slightly diminished. And so he was thinking that my surgery is unsuccessful and your one is very successful operation. So you can see, I can't see as because this is unsuccessful. So that was the thing. But nowadays, the rapid progressive technology. This is very advanced now, glaucoma surgery. And of course, that should be diagnosed properly in time, and that should be treated. So I don't think that I will take much time, as because you will speak on it. Everybody will speak on their own topics. So, and I can believe this thing that the participant will be very much benefited, and they will, the knowledge and skill which will be disseminated by your presentation, that will be very much interesting for us and also for the participant. With all these few words, thank you all, and congratulate to all the speakers, so that we can hear from you a very nice and elaborate presentation. Thank you all.
Thank you, madam.
Thanks.
Thank you, madam.
Noman,
Yes,
before
sir.
you starting,
Yes.
I will welcome on behalf of Ophthalmological Society of Bangladesh and
Yes.
Bangladesh Ophthalmic Research Forum. We are highly delighted that we are here, not only OSB, not only Bangladesh Ophthalmic Research Forum, here in Bangladesh, Glaucoma Society is here, in Bangladesh and Asia Pacific region. Our president-elect, Professor Abha Hussain, is with us. APAO Councillor, I am also, Nadim Bhatt is also APAO Councillor. And again, he is the Afro-Asian Councillor of Ophthalmology. Here we get our other speakers from India, Indore, and also Shumon Thapa from Nepal. So this is a SARC webinar on glaucoma.
Yes.
So I
Yes.
welcome all of you as you have joined. And today I am seeing that there are about 90 participants just now. I hope other participants, and after in Facebook and YouTube, there are a lot of participants, maybe more than 3,000 to 4,000. So all will be benefited. I welcome Professor Nadim Bhatt, Professor Dr. Shumon Thapa, Dr. Amit Parwal, and Dr. Bipul Sarkar, and Dr. Shams Mohammad Noman, who are the speakers. Our learned panelists, Professor Nazrul Islam, Professor Mizanur Rahman, and Nadim Bhatt, they will be with us. And our, I think, Professor Abha Hussain is always with us. Her presence always makes us in such a situation that we get honor, and also we are courageous. Today, I welcome you all, and I hope Dr. Noman, who is the dynamic organizer for this webinar and this scientific academic sessions, I hope he will start this session, and we will just complete within the speculated time, scheduled time, and I hope all the participants will learn a lot from this webinar. With these few words, thank you very much, and I welcome all of you to this webinar. Now I will request Dr. Shams Mohammad Noman to start and moderate our session. Thank you.
Thank you, sir. Thank you, Professor Sharfuddin. So I am requesting Professor Shumon S. Thapa to start his presentation on glaucoma scanning, his experience. Please, Professor Shumon Thapa, now the time is yours.
Thank you, Dr. Noman. I hope you can hear me, and I hope you can see my slides.
Yes, we can
it is-
slide. The
Okay.
other participants, please mute yourself.
Okay. So first of all, I'm very delighted to be presenting in this forum, and I thank all of you for inviting me, and I hope that I will do justice to your invitation by sharing some of the knowledge that I have with the current screening strategies for glaucoma in Nepal, which is applicable to most of our Asian countries. So the photograph over here that you see on the left-hand side is Kathmandu city. And people always think of Kathmandu as being, Nepal as being a very remote country. Yes, we are very remote in many aspects, but at the same time, we also have a very large urban population. And the photograph in the right is a mountain area that is seen in Nepal, which is again extremely remote, where people have to walk several days in order to reach and use vehicles that have four-wheel drives to be able to reach different places. So the RAP survey in 2020 that was conducted in Nepal estimated that glaucoma was the third major cause of blindness following cataract and retinal disease. So our human resource capacity currently in 2020 is shown on the table there. As you can see, there are about 22 eye hospitals, and we are about, the ophthalmologist is missed out over here, but we are about 350 ophthalmologists. Sorry, the first line is an error there. It's 350 ophthalmologists serving a population of 0.09 million ophthalmologists per population. And although this is a very old slide, but this slide really depicts how our country is divided into three different zones, which are the plains in the south, the hills in the middle, and the mountains in the north. So the mountains are the places that are really inaccessible because there are hardly any roads there, but we have almost 30% of our population residing in the mountainous area. And the rest of the 70% of the population is residing in the mid-terrain and the southern terrains of the country. And the population growth has changed over this graph now, as we see that there are a large number of elderly population. The longevity of life has increased, and we see a large number of more elderly people living in Nepal. So first, in order to understand the burden of glaucoma, what I looked upon is looking at the data that we got from the hospital. And in 2011, we did a hospital-based data where we took data from 4 different regions in Nepal: the west, the Midwest, the central part of Nepal, and the eastern part of Nepal. And we found that in the hospital, the presentation of primary open-angle glaucoma was equal to primary angle closure glaucoma. However, in 2011, we did a large population-based study known as the Bhaktapur glaucoma study. And this really gave a reflection of what we saw in our population. And we found that primary open-angle glaucoma was 3 times more prevalent than angle closure glaucoma. And the 80% of those with angle closure glaucoma were asymptomatic. And majority of the people who had glaucoma had a very poor awareness about their disease. And the main the outcome of the study, which was the most important outcome from this entire study that was conducted to examine 4,800 people above the age of 40 years, we found that the vision and intraocular pressure in about 75% or more was within the normal limit. And so this really gave us an information that screening for glaucoma using visual acuity and intraocular pressure was not a good tool to screen for glaucoma. While if we looked at the changes in the visual fields and looked at the changes in the optic disc, we found that 80% of the people who had glaucoma had changes in these 2 parameters. And again, more than 90% were diagnosed at the time of examination and were unaware of glaucoma. And similarly, angle closure glaucoma that occurred in our population was again, a large majority were asymptomatic. So screening of glaucoma has always been very controversial. Every time we go and present at an international conference, there are different views, there are debates. Should we screen? Should we not screen? I mean, the yield is so less, the money is so much. So in developing countries, we can use that money more for treatment, etc., which is very valid. But at the same time, if we club posterior segment diseases, which is actually retinal disease and glaucoma disease together, then I think it makes more sense to be able to screen for glaucoma as an opportunistic way to screen for glaucoma. And we have evidence from the early management glaucoma treatment study and different studies that is usually done in that was done in a Caucasian population, is that for a person who had glaucoma, for a person to go blind, it took many years, or probably people wouldn't go blind if they had early glaucoma detected on time. So, taking an inference from these studies, what we thought was it was very important to screen for people who had no disease and people who had advanced disease. So it was very important to club no disease and advanced disease together and focus our screening strategies based upon these two criteria. So we thought about doing a cost-effective screening using portable equipment. And at a primary level, it would be done by an ophthalmic technician. And the equipment that we would use would be a portable fundus camera and visual field testing. And if these data were teletransported to an ophthalmologist working at a tertiary eye hospital, then it would not need a patient to come all the way from a remote area to a tertiary level if the patient did not have glaucoma. Because often in our clinics, we did find that there would be an ophthalmic technician who would suspect a person with glaucoma and would tell them to go and visit a tertiary center in Kathmandu, and the person would walk 3 days, travel in a vehicle for 2 days, and come all the way to Kathmandu, and then we would diagnose the person as a glaucoma suspect within a minute and say you wouldn't have glaucoma. So that was the reason why we thought it was very important to be able to also to screen for disease, screen for people who did not have disease and were designated as glaucoma suspects. So we experimented with iPad visual field because we thought that was a great way to look at something cost effectively. And at the same time, we also took a portable camera that took photographs of the fundus, and that would be able to tell us more about combining these two results. We'd be able to learn more about the disease, and that will also increase the sensitivity and specificity of screening for glaucoma. And over here, as you can see, these are photographs that were taken by a tabletop Topcon fundus camera that would cost about $30,000. And then there would be, these are photographs taken by a picto camera, that the portable camera, which cost $5,000. And at the same time, if you see above, excuse me, that is a visual field print by an iPad perimetry that shows an advanced glaucoma, which is almost comparable with that of a Humphrey visual field perimeter. We published 2 papers in AGO in 2017 where we validated that the role of portable fundus camera and the role of portable visual field were very comparable to those of these very expensive machines. So to apply any of these devices into your clinical setting, first we would have to validate and prove it scientifically before we are able to comment further on that. But later on, as we went further, we thought, okay, why not use something that is more portable and more easily accessible? And then we started experimenting with the Paxos scope, which is something that fits into a phone. And the data was the anterior segment photographs and the posterior segment photographs could be taken, and then it would go into a database, and immediately it would come up like a notification on Facebook, and where the ophthalmic technician and the ophthalmologist were able to exchange notes and decide for the patient. So we did a phase 1 where we took 4 of our community eye centers in remote areas of Nepal, and then we transported the photographs. So the study was where a technician did a slit lamp examination, made a diagnosis, and took a photograph of the paper in which he wrote, and then he or she was made to answer whether to refer or not to refer. And then only he or she was allowed to take a photograph with this portable camera and again transport photographs to an ophthalmologist at the tertiary center. So it was a blinded study where the ophthalmic technician was to make a diagnosis based on clinical examination, and the ophthalmologist in the tertiary hospital would evaluate the clinical diagnosis against the photographic diagnosis that was made by an ophthalmologist, but the ophthalmic technician was blinded. And then we realized that 20% of the time that an ophthalmic technician made a diagnosis through clinical examination, it was missed, and that was picked up by the fundus camera. So this actually told us that it was a very feasible way of using this device in the community. And most of the diagnoses that were missed, again, was posterior segment diseases. So we found it was easy to train staff using this equipment. There was a substantial number of missed referrals, and it was most valuable in looking at posterior segment diseases. In phase 2, we took it out of a community eye centers, we took it out into the field. I mean, this field means that, these are like 2 or 3 days, 2 or 3 hours walk from the community eye centers. Some of them are even a day's walk away from the community eye centers where people have to stay overnight and screen for the disease. And it was the same test that was done, but over here we used a flashlight and a direct ophthalmoscope, and we made a diagnosis based on that. And then that was compared with, again, the camera making the diagnosis. And what we found was, again, there was the rate of agreement was least amongst posterior segment diseases between retina and glaucoma. There was a large agreement when it came to cataracts and other diseases like corneal opacities, etc. But when we looked at the posterior segment diseases, again, these diseases were picked up more by the camera. And we then published a paper just recently in 2020 about a phase 2 study. So we had a phase 1. We had a phase 1 publication also proving that the device was of value in the community eye centers, and then we published phase 2 away from our community eye centers as well. But as we all know that, to increase the specificity and sensitivity of a glaucoma diagnosis, it cannot be without also doing a visual field examination. So currently we are now looking at a portable perimeter. So this is, as you can see, this is a virtual perimetry that can be taken anywhere. And we have started a study where we are comparing the results of the virtual perimeter with the Humphrey visual field. And these are the printouts from the perimeter, as you can see, that on the left-hand side is something from the Toronto portable perimeter, and on the right-hand side is a Humphrey visual field printout. So we see that this is, again, very comparable. And we have evaluated some patients, and we are seeing promising results. And ultimately, what we would like to do in a phase 3 study is to combine the two together, to use a smartphone, do a teleophthalmology, use a visual field, and do a teleophthalmology, so that our people working in the periphery, our ophthalmic technicians, would be able to do this and communicate with an ophthalmologist in the tertiary hospital. So this will take away the need for very expensive equipment. This will take away the need for patients to unnecessarily spend their resources who are glaucoma suspects and unnecessarily come to the tertiary center. And this will also empower ophthalmic technicians to be more responsible in the community eye centers and in the remote areas of Nepal where ophthalmologists are unavailable. And hopefully by this combination, we will be able to improve the screening not only in Nepal. So Nepal is just a model of a country, but in the future, if we are able to prove that this really works, then implementing this is going to be a challenge. But with this proof, we hope we will be able to serve countries such as Nepal in the world. So with this, I'd like to say thank you very much for your attention. And again, thank you very much for your invitation.
Thank you, Professor Shuman Thapa, for your delightful presentation. You had a digital revolution, no doubt. Equipments and instruments makes everything is feasible. Smartphone and the teleophthalmology. You did a revolution, no doubt, in this glaucoma screening. Congratulations. And
Thank you
now,
very
now I was, the second speaker, very famous glaucoma specialist in this subcontinent, Professor Nadeem Hafiz Bhatt. And it's a very important presentation for for us. The trabeculectomy step by step, especially for the residents. A lot of residents are watching this presentation. Sir, you can start your presentation. The time is yours.
Dr. Nadeem Bhatt. Can you hear? Yes, you can start your screen sharing.
Yes, sir, I can. Just
Okay,
trying to bring
thank
up the
you.
presentation.
Yes, we can see.
Okay, first of all, I would like to thank the Bangladesh Ophthalmological Society of Bangladesh and Bangladesh Ophthalmic Research Forum for organizing this very nice webinar, especially on the subject of glaucoma. And I'm very grateful to Professor Ava Hussain for her compliments and for all the good words that she said about me and our friendship that is lasting more than 13 years now. We started met first time in 2007, and since then we are regularly meeting at different forums, and we work together for the SARC and also for the APAO. And we look forward that when Madam will join as president of APAO, she will be doing wonders in that organization, and we will all learn from her. I'm also grateful to Professor Sharfuddin, who holds a big cap with a lot of feathers of presidencies. He's holding, mashallah, 4 presidencies at the moment, which is a great honor for Professor Sharfuddin and also for the Bangladesh. And I'm also grateful to all the other panelists and especially Dr. Noman for arranging all this. And he is the champion of arranging webinars, and he told me that he has arranged already many webinars at the level of Bangladesh and also internationally. But now you have given this with this webinar a color of SARC, because now we have representation from Nepal, from Bangladesh, from India, from Pakistan. So 4 major members of the SARC are participating. So it's just like a SARC webinar on glaucoma. And I wish that we could have Rajvardhan Azad with us for his blessings and compliments. He's a lovely guy. He's a very good friend of ours, and he's working very hard for the SARC. So with these words, I would like to start my presentation, trabeculectomy step by step. This is basically a presentation developed for our residents and young ophthalmologists, senior people like Madam, like Professor Sharfuddin, Professor Nazrul Islam, and other guys like Noman. It will be very basic because I'm just going to show small videos of different steps. But it's more important for our residents and young ophthalmologists to learn from these steps. So this is the place that I work. It's called as Allama Iqbal Medical College. It's a purpose campus. You can see this is the area of the college with auditorium, and this building is a hospital, and these are connected with each other. And we teach in this area, and we work in the hospital, and also teach and train the undergraduate and postgraduate students. And this is the global village of ophthalmology, in which we are all serving in one form or another. Our SARC is also there, as you can see, along with the Asia Pacific, Afro-Asian, ICO, Miyako, and our OSP from Pakistan. I'm also serving at different positions, and these are the responsibilities that have been given by my country. And this is the disclaimer. So, friends and dear students, trabeculectomy by definition is a removal of a piece of the trabecular meshwork. And to my mind, this is a misnomer, because when we are removing that portion, we are actually not looking at the trabecular meshwork. We presume that under that scleral piece that we remove from the deeper part of the sclera, the trabecular meshwork is there. So similar operations have been done since 1900. The purpose is to create a new outflow channel bypassing the trabecular meshwork. And Peter Watson of England developed the concept of this trabeculectomy since in 1960. And there are improvements which have been added about every 5 years since then. In the pre-op evaluation part, we have to evaluate the patient systemically and also the ocular pre-op evaluation. Before we take the patient to the operation theater, there are few things which are very important for the assessment of the patient. And in the systemic pre-op evaluation, the patient's systemic hypertension should be around a level of 140/85. Diabetes mellitus should be under control. HbA1c at the level of 6%, and random blood sugar less than 200. And if the patient is on anticoagulation, the INR should be between 1.5 to 3. And if the patient is suffering from COPD, his forced expiratory volume 1 should be 2/3 of the normal.
Professor Nadim, can you make the presentation mode, the slideshow?
Can you please do a slideshow, sir?
That will be better visible.
Yes, okay. So in the
that's good. That's
good. Okay.
In the ocular pre-op evaluation, we have to see the limbal anatomy, especially the conjunctival and episcleral vessels, any previous surgeries or their scars, scarring of conjunctiva or superior fornix, and in the ocular surface disease, because most of the patients are on the long-term topical treatment and they usually suffer from dry eyes and also ocular surface disease and congestion. So during your examination, you have to find out the place or the area where you would like to operate and make a bleb in that particular region. In repeat trabeculectomies, sometimes you find it's very hard to find a healthy area to make another bleb as a second bleb. So in these pictures, you can see that if there is neovascularization, if there are already 2 trabeculectomies already done, then you are only left with this area that you can operate or this area that you can operate. Similarly, you can see there is a large bleb already there and involving almost 6 to 7 clock hours, and there is hardly any area left in the superior limbus to do any kind of surgery. Similarly, you can see a big bleb there and congestion all around in the eye. And if you operate here, there will be a lot of bleeding. If you operate here, there will be a lot of bleeding, and there will be the bleb will be exposed because it will not be covered by the eyelids when the patient is looking in the primary position. So the primary purpose of operating superiorly in this area is that it is covered by the upper eyelid and remains safe and is not exposed to the external environment. So when we talk about the trabeculectomy and its basic steps, there are a few steps which can be joined together in a small video. Access and exposure, surgical site, traction suture, paracentesis, conjunctival flap, and application of MMC. So I'm going to show you small videos of almost 1 minute or even less than that, and you will be able to see these videos. And then we go on to the scleral flap, and then to the trabeculectomy itself, then iridectomy, and then closure of the wound. This is the first video, and there are few people who do this step, and some people do not do this. They just start dissecting the conjunctiva. But in my own experience, if you inject a little xylocaine with diluted adrenaline underneath the conjunctiva, it gives you a cleavage plane, and it becomes very easy to dissect. And you can see with a small nick, then you can expand your prongs of your scissors and you dissect deeply and towards the superior fornix. because you have to place a mitomycin soaked sponge here, and you want to have a bleb which is flat and which is in a larger area. So this is access and exposure, and then we move on to the next step, which is the scleral flap, and you can see here the suture has been here, and most of the people have left using the traction suture on the tendon of the superior rectus, because sometimes it leads to ptosis which is not recovered, and then you have to do the ptosis surgery also later on. Then you can do the scleral flap. Scleral flap can be done with the number 11 blade or sideboard knife of the, which is used in the number 15 sideboard knife, which is used for the phaco, or the best thing to use is the crescent knife. And you can see that in this video, I will show you the crescent knife dissection. So making a straight incision with the number 11 blade, and then dissecting partial thickness scleral flap with the help of crescent knife. And the edges of the crescent knife are beveled, and so it becomes very easy. And then you can do the two side cuts after doing the dissection through the crescent knife. And these side cuts can be extended up to the limbus, or they can be kept a little short distance from the limbus. And the dissection, deeper dissection can be done. And I'll take you to the next step. And this is the iridectomy and anterior chamber reformation. The bleb and sclerectomy has been done. And another video which shows the iridectomy. So you can see that in this video, the flap has been dissected up to the limbus. And the previous dissection, and then you use the iris, and it goes back to its position, and the iris is goes deeper level, but it does not come into the bleb and should not block the bleb. So after this, the last step is the closure of the wound. And this is the final step. Some people apply sutures at the corners. Some people apply a single suture at the, just at the center. Some people make triangular flap and make one suture at the apex of the triangle. And then the important thing is to close the conjunctiva in a manner that it should be a watertight closure. And the aqueous humor should not be leaking from the underneath the conjunctiva towards the cornea. So you can apply 2 or even more sutures so that there is watertight closure. So you try to bury the sutures, the knots of the sutures, so that, and this is another way of applying the sutures at the corners, and then burying them so that the knots are not exposed and they do not irritate the conjunctiva. So they are reverse sutures. You can see the first bite is taken from the corner, and then the flap is taken and the suture becomes the reverse suture, and the knot is buried inside. So this closure is very important, because if you don't have the watertight closure, when the very next day when you examine the patient, you will see the flat anterior chamber, overdraining bleb and leaking bleb. And then you again have to take the patient to the operation theater and do some corrective surgery, which is very depressing for the patient and also for the surgeon. So it's better to make a watertight closure. But one important thing that I practice whenever I am doing glaucoma surgery or I am planning to do the glaucoma surgery, I tell the patient that I will do your glaucoma surgery and there can be few minor adjustments after the main surgery, which can be on the span of maybe next 2 weeks. So sometimes there is over draining bleb and you have to apply one suture. Sometimes it is under draining, you have to remove one suture. You can do that with argon laser or you can do that manually with the in the surgical theater. So if the patient is mentally prepared that one or two minor procedures for the adjustment of intraocular pressure may be done, they are not then worried when they are taken to the operation theater at the later stages. But one should try that that should not happen and your first surgery should be good enough for the patient. So after this closure, the procedure is complete and the post-operative course, you can see that in the initial 1 week, the blood is quite congested and 3 weeks time, the congestion is regressed. And during this time, we have to give topical antibiotics, topical steroids and cycloplegics so that the patient remains pain-free and there is control of inflammation. There is control of, we are trying to prevent infection and we are giving antibiotics. And then you can see that the bleb is smooth and soft and flattened and is extending up to the fornix because the dissection of the conjunctiva was done up to the fornix. And then gradually the congestion is gone by the time of 6 months and the bleb is functioning well. So the conclusions are that the basic steps may have a lot of variations depending on surgeon's training and experience. And the basic principles of surgery remain the same. Shallow anterior chamber and over drainage leading to hypotony is the early post-operative complication, and late complications include infection and development of cataract. With this, I thank you all for giving me the opportunity of presenting my surgical work to this August gathering of very seasoned, very senior and experienced eye surgeons from Bangladesh, from Nepal, from India, and from Pakistan. And a lot of my friends are also watching this presentation from Pakistan. And Professor Imtiaz is also watching at this time. Professor Awa knows him very well. And Professor Sharfuddin also knows him. And other friends from Pakistan, our students are also watching. And we are very grateful to Dr. Naman and his team for arranging all this. Thank you very much.
Thank you, Professor Nadeem, sir, for a wonderful presentation. What a marvelous surgery you have shown and what are the steps. I think our residents will get the benefit from this surgery. And congratulations, sir. Now I am requesting Dr. Bipul Kumar Sharkar will talk on trabeculectomy, his modifications to build a safer and effective surgical procedure. Dr. Bipul Kumar Sharkar from the Islamia Eye Institute. Professor Nadeem, can you please stop your sharing?
Yeah.
Then Dr. Bipul, you can start your sharing.
Yeah.
Yes. So, are you there, Dr. Bipul?
Yeah. I'm hearing. Nadeem sir, can you stop sharing your screen?
I'm
Stop
trying to find the. Yes, it's here. Stop sharing.
Thank you.
Yes.
Thank you. Good evening, everyone. Actually, I am grateful to Bangladesh Ophthalmic Research Forum, especially our respected research Professor Abha Hossain Madam, Professor Sharfuddin Ahmed, Professor Nazrul Islam sir, and our President of Bangladesh Glaucoma Society, Professor Mizanur Rahman, and our organizer, Dr. Shams Mohammad Noman, to give me such opportunity to talk at such a great forum. Actually, Professor Nadim Hafiz sir already done half of my job. He nicely described the step-by-step trabeculectomy procedure. Just I would like to discuss few modification of technique of trabeculectomy to make it more safer and effective for a patient. Actually, the technique of trabeculectomy is completely personalized. I believe that it's differ from surgeon to surgeon, and still now it is the gold standard glaucoma filtration surgery. And in experienced hand, its success rate up to 100%. But you need to modify its few technique, and you need to use different types of antimetabolites, and you need to apply reusable suture for getting a better result. Basically, trabeculectomy is a very simple operation, just making a hole like this. But surgeon should be very careful because this hole can invite lots of devastating complication. So that's why surgeon should be careful to avoid falling into that hole, because then your patient eyes will die. The first step is anesthesia. So different type of anesthesia we can use during trabeculectomy. It may be perivalvular anesthesia that are commonly we are using. It may be substenon anesthesia, and we can also do trabeculectomy in tropical anesthesia also. But in case of tropical anesthesia, patient feels pain. Sometimes we observe. So my question is, if patient visual field is look like that, there is advanced visual field damage, only tubular field of vision, central island of vision is remaining. So what type of anesthesia do you prefer during trabeculectomy? Actually, personally, I prefer substenon anesthesia when there is advanced field damage, because you know in perivalvular anesthesia, it creates more pressure in the perivalvular space. It may compress the compromised optic nerve, and may increase the interorbital pressure also, so there will be more chance of vision loss. But in case of substenon anesthesia, it is much safer, and it produces less pressure or compression over the optic nerve. So in case of advanced visual field damage, I prefer substenon anesthesia. The next step is, what type of antifibrotic or antimetabolite do you like during your surgical procedure? We know different types of antimetabolites like mitomycin C that we are commonly using, and now there is another antifibrotic material, collagen matrix or collagen, we are using during the trabeculectomy procedure. But the question is, which one is more effective? Which one is more safer for patient? You know, mitomycin is cheaper, it is effective, but it has few blade related complication, which is more common than comparing the collagen material or collagen matrix. And I had a study using collagen versus mitomycin C during trabeculectomy, and that was published in European Journal of Ophthalmology. I found that both are effective, but collagen is comparatively more safer than mitomycin C. This video showing the application of antifibrotic. You see, you can inject it in subconjunctival spaces by subconjunctival injection, and you can also apply mitomycin C by soft sponge under the conjunctiva. But in case of collagen material, you should implant it after the conjunctiva, after the all surgical procedure, just under the conjunctival flap. The next step is making a conjunctival flap. You can make it Fornix based, you can make it Limbal based, that Nadim sir already told. Actually, in case of Fornix based, you know, there is more chance of postoperative shallow anterior chamber or wave leaping, because there, you know, the incision site is at the level of limbus. But in case of limbus based, the postoperative shallow anterior chamber or wave leaping is less common, but it can create a scar behind the scleral flap region that may compromise your filtration function. The next step is making a scleral flap. You can make it triangular flap or you can make it rectangular flap, but both are effective. But the question is, which one is more safer or technically easier? There are different journal published in different journal, and it showed that both are effective, but technically I prefer triangular flap because it is technically easier, but the efficacy between the two flap is more or less same. In this video, I am showing the procedure of trabeculectomy only, and procedure of making a triangular flap, and now I am showing the procedure of making a triangular flap in case of combined surgery. That means trabeculectomy with small incision cataract surgery. It is same with single trabeculectomy, but at the limbus, just you need to extend it to periphery a little bit more, because you need to deliver the lens through this port. That's why I am extending it at the site of limbus, and then so that you can easily deliver the lens through this port. Now I'm showing the making a flap during combined surgery, that means trabeculectomy with phacoemulsification. In this surgery, you see, just after making trabecular superficial scleral flap, I used another port for phacoemulsification, and so that I didn't hamper the superficial scleral flap region for emulsifying the lens. The next, you need to make a trabeculectomy, deep ostium and peripheral iridectomy. You can make it pans forceps or 15-degree blade, but I personally prefer to make it by pans forceps, because it is easily visible, and you can make it large at your desired side what you need. That's why I prefer to use pans forceps during trabeculectomy, and you can make the PI at the same port. Then the most important thing is at the level of closure. Different surgeon use fixed suture, different surgeon use releasable suture. Actually, in case of fixed suture, sometimes you need to suture lysis post-operatively when there was a special spike. But in case of releasable suture, you can easily remove the suture in post-operatively when there is a high pressure. In case of triangular flap, in single trabeculectomy, I applied one fixed suture at the apex and two releasable suture at the side of the trabecular triangular flap. The advantage of is this: in postoperative period, when there is a high pressure, or in every cases, I prefer to remove the releasable suture postoperatively between 2 to 4 weeks. That's why actually advantage of releasable suture is something in your hand. If there is a high pressure, you can easily remove it postoperatively, but only in Islam procedure. So in case of all trabeculectomy, I apply releasable suture to releasable suture. And in case of combined surgery, which that means trabeculectomy and phacoemulsification, usually I prefer only single suture at the apex of the triangular flap. And if I confirm there is no visible leaking, then I didn't apply releasable suture at the site of the triangular flap. But in case of phaco, I always applied another suture at the trabeculectomy phacoemulsification port. So in postoperative period, there are few postoperative picture of my patient. You see there is a releasable suture invisible, so you can easily remove in outpatient department. So at the same time, when you need to good intraocular pressure control, obviously you need to see good bleb, good form bleb also. This is a few postoperative picture of angle closure glaucoma. In case of angle closure glaucoma, I prefer either phacoemulsification or either combined trabeculectomy with phacoemulsification. This is the few picture of angle closure glaucoma. And in case of angle closure glaucoma, always early surgery will give you good result. Thank you. Thank you so much.
Thank you, Dr. Bipul, for your excellent deliberation. And the surgical steps are really awesome, and you did really very good. And congratulations. Now I am requesting Dr. Amit Parvel. He will talk on management of early bleb failure with raised intraocular pressure. Very important topics and very burning problem in the postoperative trabeculectomy. Dr. Amit, the time is yours. Hello.
Am I audible now?
Yes.
Yeah. Thank you, Dr. Shams, for inviting me and making me a part of this webinar. I also thank the Ophthalmic Society of Bangladesh and the Bangladesh Ophthalmic Research Forum for inviting me and making me a part of this webinar. Thank Professor Awa Hussain for the kind words at the beginning of the webinar, for the introduction what she gave for all of us. I had seen her last year in the CCC conference in Kolkata. She was passing around in the scientific halls, and I saw a huge follower behind her with her. So I was not aware who was she, and I asked my fellow colleague, and I think Dr. Osama was with me, and I asked him, who is this doctor? There are so many people surrounding her. Then Dr. Osama and even Shams, you were there that time, and you told me that this is Professor Awa Hussain, and I am very, very proud. The amount of followers she has, the amount of knowledge she has shared to all the students. That's the love the students are showing her in the conference. And also almost 25, 30 people were following her when she was walking in the trade also. So thank you for making me part of this webinar. So my talk is going to be on managing early blood failure with raised IOP. I'm basically heading the glaucoma department in Chodra Netralaya, Indore. I'm a member scientific committee for All India Ophthalmological Society. I'm also the Central Zone Executive Member for the Glaucoma Society of India, the Chairman Scientific Committee for the ISM-SIC's MP chapter, and the Clinical Secretary of Indore Division of the Ophthalmological Society. I have no financial disclosures to disclosed. So coming to trabeculotomy, this is a surgical treatment of choice for many patients with glaucoma. Overall, the success rate is reasonably high as per what the people. There is 100% chances also, but the proportion of these procedures fail. Now, post-trap, what are the things which we can come across? When it comes to IOP, it can be high. When it comes to the antechamber, it can have a deep antechamber or a shallow antechamber. And when you look at the flap, okay, there can be a flat flap or an assisted flap. So today, I want to talk about a failing flap or a failed flap. Now, what is a failing flap or a failed flap?
Your audio is poor. Just audio. Yeah.
Can you please
take it towards mouth? Take it towards mouth is fine.
Is it okay?
Yeah.
Can you please increase your sound, please?
Yeah. Is it okay now, Shams?
Yes.
Better.
Yeah. So what is a failing or a failed flap? Basically, they have the increased vascularity. There's a pause through vessels appearing. The IOP is high within the first one. There can be an encapsulated high dome appearance of the flap, or the flap can be a flat localized, or there can be an absence of microcyst. So these are the pictures showing various types of flaps. Now, when coming to a raised IOP with deep penetrate chamber, what are the causes? There can be intraocular cause, the ocular cause, and extraocular cause. The intraocular cause can be due to the internal obstruction by blood, fibrinous clot, iris, or the vitreous. The ocular cause can be a diffuse fibroblastic proliferation, and the extraocular cause can be due to tight scleral sutures. So, failing flap when you have an uncontrolled IOP and deep AC, how you are going to proceed? Always do a gonioscopy first. Look for the obstruction to the flow at the scleroderma site. Obstruction with mild fibrin and minimal blood is transient and it does not need any intervention. Whereas if the internal obstruction is obstructed with iris or vitreous incarceration or there is a dense fibrinous membrane, you can consider laser internal division or a surgical intervention. If there is a dense blood or fibrinous clot which is occluding the fistula, you can inject tissue plasminogen activator intracamerally. Coming to digital ocular compression, it is indicated in the early post-operative elevated IOP and a flat flap. Basically, it separates the edges of the scleral flap by expanding the subconjunctival space. It decreases the IOP and elevates the flap. It is not effective in blocked fistula. Now, the technique of digital compression should be taught to the patient. It is very, very important. A slow, steady pressure for about 15 seconds is applied. It is applied with the index finger to the inferior sclera to the lower eyelid or the sclera posterior adjacent to the flap to the upper eyelid. This second step is performed by the ophthalmologist, whereas the first step, which I told, the inferior sclera to the lower eyelid, lower lid, it can be taught to the patient also. A focal compression with a moistened cotton tip applicator at the edge of the scleral flap can also be done by the ophthalmologist. Now, whenever you do a digital compression, you should always look for the AC depth, the height of the flap, and the IOP should be noted after this. If successful, then it has to be repeated several times. And if the IOP remains high, the removal of releasable suture or laser suture has to be considered. Now, coming to the releasable suture, there are different techniques of putting the releasable suture. Dr. Vipul showed his technique. My technique is a bit different. Now, what are the advantages of releasable suture? It allows tight closure of the scleral flap. The aqueous flow can be increased post-operatively, and the externalized suture can be easily removed. So, when I'm putting the releasable suture, I first take a clear bite into the clear cornea, parallel to the limbus, and then from the limbus, perpendicular to the from the clear cornea, perpendicular to the limbus into the scleral flap, and then from the scleral flap into the intact sclera. And then I take four throws and pass these four throws over the loop which is created over the scleral flap, and this way the releasing suture is taken. The various techniques are, as Dr. Vipul was mentioning, I initially when I started with my trap surgeries, with my releasable sutures, I used to take one apical intermittent suture and two releasable sutures. But now, whether I'm doing an SICS trap or a FIPO trap or combined surgery or as plain trap, I always use one releasable suture at the apex, and that's how you, you titrate yourself as you go on proceeding with the surgeries. With the experience, you know how many sutures you want to put. So I usually now do only one releasable suture. The advantages of releasable sutures are already mentioned. The main thing is there is an exposed end on the cornea. The releasable suture can be released into the OPD itself. You can see on the cornea that this is the exposed end of the releasable suture on the clear cornea, which is parallel to the limbus. With the plain forceps, after anesthetizing the eye, you can just release it. You can also titrate the opening. You can release a bit and see whether the bleb is forming or no. And if you want to stop it then and there, you can just trim it off. And otherwise, you can release the whole suture and see the elevation of the bleb. This is very, very important technique, and most of us who are doing trap should switch over to releasable suture if they're not doing the releasable suture technique. Coming to organ laser suture analysis, the timing is critical. It is effective within first 2 weeks after the surgery without anti-metabolites. But with metabolites, it is effective for several months after the surgery. A conservative stepwise approach has to be done, and one suture should be cut at a time, and then the bleb titration should be noticed. Coming to the technique after using topical anesthesia, a Hoskins or the rich lens is used. These lenses, they flatten and blanch the overlying conjunctiva. You can also use the central button of the size of the Sussman lens. 50 micron spot size, 0.1 second, 200 to 500 milliwatt power is used. You can see in this video that how the laser is shooting at the suture and the suture analysis is being done. Now, why these blebs fail? Basically, these blebs fail because the patients have a rapid wound healing response. There can be a subconjunctival fibrosis. When there is a subconjunctival fibrosis, the incidence of failure is approximately 20% in the early period and 30 to 50% in the late post-operative period. Coming to the subcutaneous encapsulation of the bleb, it usually occurs in the first 6 months after the surgery and is seen in 10 to 20% of the patient after trabeculectomy. Antimetabolites, Dr. Vipul had already covered in his talk. Basically inhibits the fibroblastic proliferation. We have the two main antimetabolites which we use in a trap surgery. It is mitomycin C and the 5-fluorouracil. Coming to mitomycin C, it is 100 times more potent than 5-FU and kills all cells regardless of their fires in the cell cycle. You can use a subconjunctival injection of 0.02 to 0.04 milligram per 0.1 ml. Topical 0.02% drops 4 times a day for 2 weeks can also be used post-operatively. 5-fluorouracil, it basically inhibits fibroblastic proliferation by killing the dividing cells. You can use subconjunctival injection of 5-FU, which is the dose is 5 milligram per 0.1 ml. Total dosage being 15 to 50 milligrams in 3 weeks' time. You always watch for blood features, corneal complications, and wound healing. The important thing is the corneal complication. MMC is more endothelial toxic and 5-FU is more epithelial toxic. So you have to be always observant whenever you use these antimetabolites and the patients come for follow-up. Coming to bleb needling, which is a technique which is used for failing bleb or encapsulated high dome appearance bleb or a flat localized bleb. Now, what is the goal of needling? It is basically to re-establish the fistula from the anterior chamber to a subconjunctival bleb where aqueous humor may be reabsorbed. So bleb bleeding, I'm showing a video. Basically, it is indicated for flap and encysted bleb. You can see in this video, I'm doing this procedure in the OPD. Again, it is a debatable issue whether you should do this in the OPD or in the OR. I look at my ease and patient's economic condition and then decide where it has to be done. So this is the bleb needling being done in the OPD on a straight line. 27 gauge needle is done. The needle is passed at 5 millimeters away from the lateral edge of the bleb subconjunctivally, and with a to and fro motion, it is advanced forward, and then it is gone behind the scleral flap. So by using a to and fro motion, you are cutting all the septic fibers which are there, and then through the internal ostium, you can enter into the anterior chamber. This is the way the bleb is done. This is a picture where it was an encysted bleb, and after the needling, this bleb has become flat, and it is smooth bleb. Again, bleb needling can be combined with mitomycin C. Now, this bleb needling was being done into the operation theater. A stay suture, a corneal stay suture is being taken. And once you take the stay suture, it uses a better exposure when we are doing the needling. So the stay suture is very, very important. And as Dr. Nadeem also said, that instead of a superior rectus stay suture, it is always advisable to take a clear corneal stay suture. Now, once a stage photo is taken, you expose the bleb area by pulling the globe down inferiorly, and mitomycin 0.1 ml, that is 0.02%, 0.02 milligram per 0.1 ml, is injected as much posterior to the bleb as possible subconjunctivally. Once this mitomycin is injected, wait for 5 minutes, and after you waited for 5 minutes, now you can see that the mitomycin is injected. After you waited for 5 minutes, when you're going to start needling, always iron out or brush the mitomycin which you have injected as much posteriorly as possible. You don't want any mitomycin to come anteriorly and into the anterior chamber. So brush it out or iron it out as much posteriorly as possible. Once it is done, you can take a 27 gauge needle or a 26 gauge needle on a tuberculin syringe with 1 ml syringe. You always bend the straight needle into a L form. So once you bend this into a L form, partial L form, and or a diagonal 45-degree angle, you have a more easy control when you're doing the bleb needling or when you're trying to dissect the subconjunctival fibrous tissue. You can see this needle is bent now. So this is a 26 gauge needle I've taken. I'm injecting subconjunctivally about 5 millimeters away from the lateral border of the bleb, and I'm making a to and fro motion trying to dissect all the subconjunctival fibrosis which is there. Now I can see that I always do a triangular scleral flap, and I can make out that the triangular scleral flap is there. So I go beyond the scleral flap at the other side of the bleb also to cut the subconjunctival tissues as much as possible. And now I'm entering into the subscleral flap and trying to separate the adhesions which are there into the subscleral flap. You can see that as I'm doing it, you have to be very careful to avoid the vascular vessels, because you don't want bleeding to occur, but sometimes you can't help it. The vessels do bleed because these filling blades have off-through vessels. So once you are going subsclerally, then through the internal ostium, you pass this needle into the anterior chamber. And there also you do a to and fro motion, observing clearly at the tip of the needle that you don't traumatize any of the cerebral tissue. And once it is done, you can see, once you enter the internal ostium, you can see my needle is now into the anterior chamber. And once it is done, you can start see that the bleb is being formed. So this is the technique of doing a bleb needling. And once this is done, reform the anterior chamber and see if the bleb is patent or not. You can now see that the bleb is being formed. So the needling is successful. Post-operative, you have to manage, you have to see how you are going to manage this needling. So these are the pictures basically of this patient before the needling. And once the needling is done, you can see in the OCT picture, there are multiple small cysts. And this is how the bleb appears after the needling is done, post-operatively after 1 month. So change in the appearance of the bleb is seen during or soon after the needling. After the needling procedure, antibiotic steroid drops are started. Registered massage has to be initiated early and continued for a longer time. Needling can be complete with subconjunctival injection of MMC or 5FU combined with 0.1 ml lidocaine. It can be given superior-temporally before needling and then massage for 2 to 5 minutes. Blebs with thick scar and quick failure, mitomycin is very useful, while those which succeeded longer and failed slowly may respond adequately to 5FU. So the key to successful post-hospital management is early recognition of failing bleb and correct selective and selection and timing of the various interventional options which are available. Thank you, and for any queries, I'm always available on this is my mobile number and my email address. Thank you.
Thank you, Dr. Amit Parvel, for your beautiful presentation and beautiful postoperative bleb management with high intraocular pressure. Excellent. So now
it's the time for Shams Muhammad Noman,
yes, sir.
who cannot declare himself. So
Yes.
we will request Shams Muhammad Noman for his presentation. And if you start your screen share, Shams
Yes,
Muhammad Noman.
Honorable host and chairman of this session, guest of honor, honorable panelists, and my dear speakers, it's my pleasure to be with you with a little contribution within this presentation, glaucoma drainage tube. I'm Dr. Shams Mahmoud Doman. This is my institution picture, aerial view, Chittagong Eye Infirmary and Training Complex. I'm really, I should show my gratitude to my institution that for this institution I am today. So I have no financial disclosure for this presentation. And the topic is tubes, glaucoma tubes, and usually we implant in a refractory glaucoma. And the indications is refractory glaucoma that creates some headaches, and also it makes us in a very complicated situation, what to do and what not to do. And what are the commonest refractory glaucoma we do face is neovascular glaucoma, exenfil Rieger syndrome, iridocranial endothelial syndrome, aphakic or pseudophakic glaucoma, uveitic glaucoma, post-PK, failed trabeculectomy, and congenital glaucoma. And in my experience, I used to face some glaucoma with refractory, like neovascular glaucoma, iridocranial endothelial syndrome, pseudophakic glaucoma, especially in case of children, post-PK, failed trap, and congenital glaucoma. Am I audible, sir?
Yes, yes. You are audible.
So refractory glaucoma is a challenge, but we have to take the challenge. What's the problem? 3E, I used to tell that 3E. One is the tube is expensive, it needs an efficiency, and it needs an experience. And yes, it is possible. If we achieve 3C, care to the patient, we have to take care of the patient, we have to think of the patient, that we have to relieve the signs and symptoms of the patient because he or she is suffering. We have to achieve the commitment, we have to achieve the confidence about the surgery with our experience. So type of tubes. Based on the type of the opening, implants can be classified into non-valved and valved. Non-valved rely on the resistance formed by the fibrous capsule or bleb. Bleb grows around the implant and creates a space for fluid to drain and be absorbed by the surrounding tissue, like Barvelt, Orbint aqueous drainage implant, Molteno. And what are the valves? This is the most commonest. Is the valve, the Ahmed valve, only drains fluid at a certain intraocular pressure. Valve opens and fluid is drained into a reservoir, whether it is absorbed by the surrounding tissue. The Ahmed is the most commonest valve being implanted worldwide. What about the non-valve devices? The commonest is Barvelt in the European region, and in the Indian subcontinent, the Adi is a very preferred usable. And the large, what is the advantage of Barvelt is the large surface area, 250 and 350, two types. And you know the locations is superior temporal quadrant under the rectus muscle, and inserted through one quadrant, conjunctival insertion. And you can see in the picture some fenestrations. These fenestrations for the fibrous tissue comes and from the bleb and capsule formation later on. And a flow-restricted drainage device like valve, the Ahmed glaucoma valve, most commonly used. The commonest is a P7 for the adult and a P8 for the child. And a P7 is 184 millimeter square. It's single valve, and it has a single silicon tube with a polypropylene body. Sometimes a lot of residents usually ask questions about what is important, what is the advantage and disadvantage of the valved and non-implant. There is a very big study and very famous study went on, ABC study, the Barvelt, Ahmed Barvelt comparison study. It's a long-term result. What is the result? The four important result. Success rate is more common, is more in the Barvelt implant, long-term success rate, but the hypotony is more in the Barvelt also. This is also dangerous that, you know, the hypotony management is a challenge and it may create a blindness. And postoperative anti-glaucoma is needed less in the Barvelt. That is also great advantage of Barvelt. But immediate intraocular pressure control is more in the Ahmed valve, because you know in the Barvelt tube you have to close the tubes and you have to wait for the suture become lysis, and intraocular pressure will be reduced. So immediate postoperative intraocular pressure reduction is not very good in the Barvelt implant, but it is quite good in the Ahmed valve. So actually now I will show you 2 or 3 videos about different steps of different implants. So in the first case is in a childhood with a pseudophakic refractory glaucoma. I'm going to implant a mid valve. I'm telling it a journey towards the musical hopes. We have a very good musician, Professor Shuman Thapa. So we are tracking a traction suture with a 7-0 black silk corneal traction suture. And conjunctival peritomy is going on. We have to make a very good space because, you know, you have to accommodate the total plate of the valve. And now I have marked the anterior part of the plate where I have to fix it up. And now the priming is done. The priming is very much important to see the patency of the tube. Now valve is placed. For the residents, this is also very much important to observe the steps of the implant. And now the anterior margin of the plate is fixed with the sclera. Usually I used to fix it with the 9-0 silk. Now needle track is making now I'm inserting the tube. Before inserting, I have to cut the tube to make a measurement. And during insertion, we have to think that the tube inserted will not be too long. It should not be touch the cornea, should not be touch the iris. Now the tube is sutured over the sclera. Now I will make a patch graft with the tutoplast. This is a pericardium, processed pericardium. It is quite expensive, not very much available in this subcontinent. Now the patch is covered over the exposed tube. The ideology of the patch graft to prevent the exposure of the tube exposed and to prevent the conjunctival rubbing over the tube that might cause tube exposures through the conjunctiva, and there might be possibility of infection and also the failure of the implant. Now the peritomy is going to be closed. I used to close the conjunctiva with the 8-0 Vicryl suture. Tight closure is very much important because if it is not tight, the plate can be come out through that loose conjunctiva. This is a plate and you can see the tube within the antechamber. It's a patent tube and it's working good. This is the tube. The cornea was edematous. The preoperative 660, postoperative 636, preoperative 54 millimeter of mercury. In the postoperative, it is 12 millimeter of mercury. Thank you. Now I will show you another video. That is, I'm telling it history of a victory beyond expectation. That is also a refractory glaucoma. And here, I will not use patch. I will just use the patient own sclera to cover the tube. This is a case of iridocorneal endothelial syndrome. And she has a very high intraocular pressure. Patient was underwent 2 trabeculectomy, and ultimately we had planned for a valve implantation. We are implanting a mid valve after creating a great space Now the valve is fixed. The fixation of the valve is very much important. If it is loose, the valve can be exposed. Now I'm creating a superficial scroll flap here. Usually I used to do a 5 or 6 to 2 or 3 millimeter scroll flap. If it is wider more, the less chance of exposure. So self-scroll flap is made. Now the tube is going to be cut down after measurement. Needle track is done for the insertion of the tube. Sometimes there is some blurring of the videos because different depth. You have to make a video for the from different depth. The self-scroll flap is sutured over the tube, and now the peritube is going to be closed. And now you can see the tube in the anterior chamber, and the girl is doing very good now. In the last follow-up, she had intraocular pressure of 10 millimeter of mercury.
Very.
So, am I audible, sir?
Yes.
Yes.
This is a non-valved, this is an animation of non-valved RD implant. The difference between that valved and non-valved, this Bordwelt or RD, you have to put it under the muscle between the superior rectus and lateral rectus, and then you have to fix it. This steps is very much important for the residents also, and also for the to compare with the other surgeries. Now the tube is fixed within the sclera. No scleral flap is done, nothing. And you can see in the non-valved implant, you have stitched the tube, and no fluid can come. Just we have to fix the tube, and also we have to close the tube with the vicryl. And needle track is made, needle track. And the tube is inserted into the anterior chamber. And tutoplast is covered over the tube in the same manner. And you can see through the pores, there are some fibrous capsule covering the whole surface area of the RD or Bordwelt. And after a few months, when the vicryl suture become lysed, then the fluid comes and it creates a great bleb. That is the most important, that after lysis of the suture, the bleb is formed, and for the long term, the result is really very good. But immediate postoperatively, intraocular pressure can be high. So this is also very much important point to be taken out. So this is my surgery, Bordwelt tube implant in a refractory glaucoma, hope in the darkness. I'm doing a peritomy here with a large peritomy, and I'm isolating the recti because we have to place this Bordwelt implant under the rectus muscle between the superior rectus and the lateral rectus. This is a very challenging situation in that in this situation, muscle can be injured, muscle can be torn. This will create a hemorrhage, and a postoperatively patient may develop a squint. Needle track is done. Now I am fixing the implant. In the Bordwelt implant, it is better to block the tube with a supramid suture, 3-0 supramid suture. Now the tube is totally closed with the vicryl, and patch is implanted, the tutoplast. We can use self-sclera, we can use the dried sclera, dried cornea, Tutoplast is a processed pericardium. This is quite expensive one. Now conjunctival peritomy is going to be closed. Tight closure is very much important for the Bearvelt implant also, because Bearvelt is a large implant, so it has a tendency to be exposed. And I hope we will make another glaucoma series webinar in the next, topic will be only the tubes, where we will discuss on the implant and different other implant surgeries. Hope we will attend.
Yeah.
So it's all set, done. So this is my institution, aerial view, and I'm requesting all you will visit Bangladesh, the beautiful Bangladesh. Thank you, our respected foreign speakers, to be with us. And we are planning to make a SARC Glaucoma Association. I think we will propose it in the next SARC Academy of Ophthalmology conference. Thank you, everybody. Thank you.
Thank you, Shams Muhammad Noman, for your nice, excellent presentation with some videos. I hope it will be very much helpful for the residents who have not yet seen even the bulbs, non-bulb, and the bulb, Ahmed bulb or Adi. They have heard the name, but not even seen. I think this presentation will help our residents and even the new surgeons who want to use the valves. Thank you very much. I hope now there are a lot of questions, about 11 questions are there. I hope each speaker will have 2 questions. I think Noman, you will select 2 questions from each speaker, and after answering these questions, we will go to our panelists for their comments. Thank you. Noman.
Professor Sharfuddin, just
Yes, madam.
Just 2 words. Sorry,
yes, madam.
as because I have to leave now, as because there is another program waiting for me. Before
madam.
leaving, I would like to thanks and congratulate all the presenter. Excellent presentation. I have so many questions to ask to everybody, but I could not do that. Only one thing I would like to know from Shumon Thapa, the Bhaktapur glaucoma survey, that is almost open angle glaucoma, and all the patients are within normal limit. That is whether it is normal tension glaucoma. Dr. Shumon, can you hear me?
He should unmute. Yeah, unmute. Yeah.
Yes,
I can hear you.
Please unmute. Yes.
Okay.
Okay, madam. Again, question.
No question now. So thank you so much, panelists. Sorry, I could not hear your just what you were explaining the question, or the add your own own skill, own knowledge, own experience. But still, Professor Nadim, Dr. Amit, Dr. Shumon, Dr. Nazrul, Mijan, and Bipul, Noman, everybody, Professor Sharfuddin. Thank you so much. Please give me permission to leave.
Thank you, madam. Thank you, madam.
Thank you,
Thank you.
madam.
Thank you.
Thank you, madam.
Again, as because you are now leaving us, I hope I will talk to Nadim, and very shortly in the middle of the August, either 20 or 18th August, we will go a SARC webinar where Rajbardhan Azad will be with us. And
Yes.
here,
Okay.
at that time, we will ask, you will give a lot of time to give your
Yes.
comment. Thank you,
No,
madam.
Today also I have given whole time. Sorry.
Yes, thank you, madam.
Not
Thank
I can
you.
complete. Sorry.
We want the ending of yours, but I hope you will be with us whole time. Thank you very much, madam, for
Thank
joining
you so
us.
much.
Thank
Thank
you.
you so much.
Thank you. Thank you. Madam
I
is
want to
always
comment
with
one
us.
comment in terms of madam.
Yes.
Yes,
It's
I'm
our
always
pleasure.
with you.
It's our
I'm
pleasure
always
to
with
Thank
be
you.
any meeting with madam.
Yes.
Thank
She
you
is
so
our
much.
great
Thank
teacher, and whenever madam
Amit?
is there, we feel so easy, and she's our inspirator. So
Yes.
definitely, when madam is here, we are really thankful to madam.
Madam, one thing before you're leaving,
Yes.
Dr. Amit Paral, he is the chairman of the scientific subcommittee of ISM SICS Madhya Pradesh chapter.
Yes, I know. I
On-
know. I know. I am asking Amit.
On 31st, I will give a presentation in the installation program of Madhya Pradesh chapter ISM SICS. So on behalf of Madam, she is our chairman, ISM SICS, and me, Professor Mizanur Rahman, is the president of ISM SICS. On behalf of ISM SICS Bangladesh chapter, I congratulate you.
Thank you. Bye.
Thank you.
Thank
Try
you.
to
Thank you.
invite us when you will have this type of webinars. Thank you very
Oh,
much.
sure.
Thank you.
Sure.
Thank you.
Thank you.
You are
Thank
one
you.
of us, Professor
Yeah,
Shafruddin.
sure,
You
sure,
are-
Yes.
sure. Thank you, madam.
Yes.
Thank
If
you.
I get time, I will be there.
Yes.
Okay.
There is a question for the Professor Suman Thapa.
Yes.
Now, how do you manage your, in the screening program? Do you have any sufficient paramedics or optometrists with you? And what is their role in the screening purpose? And another question is, say, you have to purchase very portable things like fundus camera, portable visual field, and a lot of things, and it is very much expensive. So very common question is, what is the source of your, fund? Actually, how did you collect the fund? So we have a lot of people, they want to do a glaucoma. We have also explained the glaucoma, but this is our first question to you, Professor Shuman Thapa.
So, yeah. So the thing is that when we screen for glaucoma, at this moment, we have our ophthalmic assistants. They are trained, and they are working. They have been trained in a 3-year program. So they are looking at anterior segment and posterior segment diseases. But like glaucoma is a very difficult disease to detect by ophthalmologists. Sometimes they erroneously diagnose people with glaucoma. Sometimes they do not diagnose people with glaucoma, and most of the time do diagnose patients who have glaucoma correctly. But for ophthalmic technicians, it is even a bigger challenge because their training, although it is for 3 years, they don't have the experience like ophthalmologists. So what we had once done was also had enhanced training. We had given them a special glaucoma extra training, but then we realized that really also doesn't work, because in the end, it is really how much they apply themselves into looking. So in our community, centers around technicians. We have about maybe 25 community eye centers, at least our hospital has. So they are looking at glaucoma patients and referring patients whenever they say patients who have applied themselves in eye centers around. But for ophthalmic, that with our study, what we have done is that we have proven that instead of transporting the patient, if you transport the photograph of the patient, then that works. So at this moment, we have provided community eye centers. We have provided the Paxoscope. That is that which takes the photograph, but we are still experimenting with the visual field, so we haven't been able to give them the visual field. But the Paxoscope is very easy because it can be used on a phone, on a smartphone, and it can take photographs. So we have been successful so far, but now with the visual field experiment, when the results come out, then combining them will help. Now, how much they cost is, see, even the Paxoscope is costing less than $1,000. So everybody has an Android phone or a iPhone. In our country, mostly Android phone. These things can fit into that. So that practice is costing less than $1,000. In fact, in reality, it's costing like $200 or so without the lens. And the portable visual fields will ultimately cost less than $5,000, maybe $3,000, $4,000. There are already ones that are available for $7,000, so it will cost maybe $3,000-$4,000. And the funding, of course, is like, because we are a tertiary hospital. What happens is that we subsidize from the profits of the cataract operation to cover other costs. So that is one. But at the same time, it is also that we have also donors, who help in this, like that are not sustained because they are in remote areas. So sometimes we can approach our donors who can, provide money to buy.
Yeah.
I have a
Okay.
Dr. Numan. Can I ask
Abdul.
one query to Professor
Yes.
Suman Thapa?
Yes, sir.
Yes.
Professor Suman, actually, your presentation was really brilliant, and it is very encouraging for us, even
Thank
for
you.
Bangladesh. How can we do the study like another BGS? You know that Bhaktapur Glaucoma study is also BGS, and our society is also BGS, Bangladesh Glaucoma Society. So whenever you have done the landmark, the Bhaktapur
Right.
Glaucoma study, actually, it really helps us to encourage to do the study in this subcontinent. The problem is, as Dr. Numan said, is the budget. And as you have shown, the smartphone, the
So everybody has
iPad,
an Android phone.
yeah, Android phone, visual field, so it is really encouraging that we can do a small budget. So I have one question. You have also shown the RAP survey in 2020. So my question is, you already have done a very big Bhaktapur glaucoma
Yes.
study group, and you got some information of prevalence of glaucoma in your country. But what informations you are expecting to be more information in your RAP survey in 2020? Got my question?
So
Suman Thapa?
the survey, as we know, yeah. So the RAP survey, as we know, it is mainly for avoidable blindness. It tells you, it
Okay.
gives you it's like looking at the tip of the iceberg. Now, it really covers most of the things with refractive error, covers the prevalence of cataract and blindness from cataract, the cataract surgical coverage, and now in the new RAP, they have also added a diabetic retinopathy treatment protocol. So it also looks into that. So it gives you a little bit, but the RAP service, I personally feel, is an underestimation of glaucoma. Of course, doing such a big glaucoma study like the Bhaktapur glaucoma study, where you have to follow the criteria of the ISGO, you have to follow all the standards that have been laid by the Western countries, which is a base. And sometimes I think that us being Asian countries, we don't have to follow the ISGO as well. I mean, these are standards for very well equipped, very developed countries. For our own sub-countries, we can develop our own standards. We can develop, and I think that is going to be justifiable. And we don't have any so-called strategies that have been, like we want our papers to be accepted in international journals. We want it. I mean, that is fine. But in reality, we know what the scenario is because we are on the field always working. So the RAB, a little bit of a touch on glaucoma, but for any full study on glaucoma, one has to do, gonioscopy. One has to do intraocular pressure measurements on all patients. One has to know what is normal. One has to know and the fields on suspects. So all things are not possible with the RAB. And the reality is that glaucoma, it varies from races. It's a genetic disease. Like in Nepal, it can vary from one ethnic group to another ethnic group. And I'm sure in Bangladesh also, one ethnic group in Bangladesh will have one kind of glaucoma more, the other ethnic have it. So one study will not represent the whole. For example, if you do in one district, one population, not going to represent the entire country. So doing different glaucoma studies in various places is very expensive. But however, if you do in a large population, it will give you some idea into your population. It will give you an idea data into what is normal in your population. And also it will also be able to tell you that what the real scenario is. So you have to choose a population which you think will represent majority. For example, the Bhaktapur glaucoma study, it does a Bhaktapur district represents Kathmandu district represents entire Kathmandu Valley, and because it is a large study, like for almost 5,000 people, it does represent a large part of our valley. So in that way, the results can be extrapolated for areas like Kathmandu Valley. But again, it doesn't represent what is in the West. But however, the learnings from the Bhaktapur glaucoma study have shown us that we are not really looking at the prevalence of glaucoma as important, but at the same time, what the knowledge that we got was those parameters that I was talking about, these changes. Those two parameters to look more into ways to screen, look at optic discs, portable equipment, look into the fields. So I think that learning now, if that proves to be applicable, we don't have to do all the seminars and just go straight with the screening strategies and detect glaucoma. Because ultimately in the end, one study should be able to help us find defined tools which will be for glaucoma in different places. Yes.
Thank you.
I want to add,
do
Dr.
you
Nazrul.
need the
Nazrul.
OCT? One question for him, that do we need the OCT in the glaucoma study screening? What is your experience? Because in Bangladesh, we are planning to make an epidemiological study, but some of us are thinking that really do we need OCT in the screening of glaucoma study? What is your experience? OCT, because you have not used OCT.
Yeah.
So what is your experience? Is it really needed for the screening?
No, not at all.
No.
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 I want to
Thank
add,
you. Thank you very
Nazrul.
much. Thank
Dr.
you.
Nazrul,
Thank you.
Shomon Thapa, in our country, we have 2 pilot projects now, Community Vision Center, where we have some paramedics and nurses who have been trained for 6 months. But in our country, there is not lot of ophthalmic technologies. Do you think within 1 year, not 3 years, if we can make 1 year training of MLOP, where this type of people will go to, for 2 things. One is fundoscopy, another is portable visual field analysis. If within 1 year, this type of medical technology, ophthalmic paramedics we can produce, I hope we can make 2 things, screening, diabetic retinopathy screening and glaucoma screening from this type of study. And the instruments that we can also procure in the government level and also in some of the private level, like Joshua Community Eye Hospital. You can also supply there, and you can also supply, you can train some people and they will go to Joshua area, even Kashiani, Gopalganj area. And from there, we can also bring some idea.
Yes.
In this way, in future, we will proceed on. Thank you.
Thank you. We have some questions from the audience to Professor Nadeem.
Yes.
That how do you manage pupillary dilatation during trabeculectomy? The first question. And we have a lot of foreign attendees from Nigeria. I saw from the Ivory Coast, from the different parts of the South America, Pakistan, India, Sri Lanka, and one doctor from the Nigeria, he asked you that what is the role of paracentesis before trabeculectomy? You have 2 questions.
Professor Nadeem. Please unmute.
Please unmute, sir.
Can you repeat the first question, please?
First question is, how will you manage pupillary dilatation during trabeculectomy? If it is a pupillary dilatation during trabeculectomy, you have seen that the pupil become dilated. In that case, what you will do?
It all depends, my standard practice is to instill pilocarpine before the patient is taken to the operation theater so that the pupil is quite constricted when the surgery is started. But if during the surgery, the pupil is mid-dilated, it usually doesn't affect the formation of bleb. But when you open the anterior chamber after doing the deep sclerectomy, the iris can bulge into the wound if the pupil is dilated. So at that time, you can instill 1 or 2 drops of carbachol in the wound, and that carbachol will immediately act and the pupil will be constricted back. So that's not a problem to manage, and it can be done very easily. And the second question is, what is the role of paracentesis? The paracentesis makes the eyeball a little softer before the opening of the anterior chamber, and it prevents the sudden drop of IOP when you open the anterior chamber after doing deep sclerectomy. So if the paracentesis is done beforehand, it will not drop the IOP suddenly and will avoid the choroidal, the hypotony and the choroidal perfusion and development of choroidal detachment. So it will save you from all those complications that can happen because of the sudden drop of intraocular pressure. So these are the answers to the two questions. Is there any more question for me?
Can I ask
Yes,
one question to Professor Nadeem?
Nadeem from me. One question
Okay,
to
after
Professor
Professor
Nadeem.
Nadeem.
One is
Yes.
that if a patient having a dry eye and glaucoma, in that situation, what precaution he will take and what measure he will take?
First of all, you have to actually examine and evaluate what is the level of dry eye. Is it a severe type of dry eye, a moderate or mild? And put the patient on appropriate lubricants well before the time of the surgery. And also try to reduce the anti-glaucoma medicines as much as possible, because these are the drugs which are responsible for the dry eye and ocular surface disease. So use of lubricants before and after the surgery will help the patient from side effects or symptoms of dry eye.
Yes, thank you.
I wanted
And
to ask
even after
Professor
surgery,
Nadeem.
it will be continued.
We can
Professor
use the
Nadeem.
continuous lubricants.
First of all, thank you very much for your very good step-by-step trap. I think it is really useful for the residents. I have two queries to you that do you use subconjunctival low-dose concentration mitomycin in your
Yes, sir.
trabeculectomy?
Yes, sir. I have recently started, few months ago, I started
Okay.
using mitomycin diluted instead of xylocaine with adrenaline to raise the bleb. And that gives a cleavage plane for dissection and
Yes.
also affects the mitomycin effect is also achieved. Then you don't have to place the soaked swab under the flap or here
Yes,
and there.
yes,
And by
yes.
the time you finish you do the conjunctival dissection, then you wash it thoroughly so that the mitomycin that is there is washed and cleaned thoroughly and it does not affect the cornea or your wound. So
Now
that is a
yes.
good step for using the mitomycin.
Yes, I actually use for last 3 years and I don't have any problem. So I feel it's really good way. A second question to you, during your surgery, if the antechamber become very shallow, how do you manage?
During the surgery, you can use the viscoelastic, and from a side port, a small paracentesis, you can inject the viscoelastic, and that will stay in the anterior chamber. And when you close the wound, you can also leave, some of the surgeons leave viscoelastic at the end. Some of the surgeons use air bubble to check the patency of the
Yes.
bleb and also maintain the anterior chamber. But that air bubble will be absorbed in next 24 hours, whereas the viscoelastic stays there for about 48 to 72 hours and maintains the anterior chamber.
I believe that air is very good because it does not have any complication. If you put
Yes.
air, it's really
But-
good. It does not have any complication, and usually it
but-
goes after 2-3 days.
What about
Okay, Nona.
mitomycin C application under the scleral flap? Do you use mitomycin C application under the scleral flap?
Just the partial thickness scleral flap. Yes, I apply there. I apply there, just I touch it there, touch the mitomycin there, and then wash it thoroughly. Because the scarring is happening at two planes. It is happening between the partial thickness and deeper scleral flap, and it's also happening between the conjunctiva and the sclera. So we have to protect both planes from scarring. So if these planes, any of these planes is scarred, the flow of ecosumor will be hampered. Therefore, touching the mitomycin just underneath the partial thickness scleral flap is useful.
So I saw some of one study that some group of glaucoma surgeon in this subcontinent, they don't want to use the mitomycin C under the scleral flap because they want to tell that it absorbs through the sclera and it may cause it may attach with the ciliary body and may cause the cyclitis, postoperative cyclitis. So they have also published one study about that. So I have a questions to the Dr. Amit Parwell, here's a very nice question about the what is your thinking? What should be the ideal criteria of the good bleb? And the second question is, do you use anti-VEGF in the case of failure bleb? Please unmute yourself.
Yeah, coming to the second question first, I don't have any experience on anti-VEGF in a failing bleb, but yeah, I've gone through quite a lot of literature. Anti-VEGF can be used intracamerally for failing bleb if the internal ostomy is patent, but I as such don't have any experience with the anti-VEGF. Coming again to your first question, Shams, can you repeat the first question? What was it?
First question is, what do you define an ideal bleb in your cases?
An ideal bleb should be a diffuse bleb. It should not be too elevated. It should be a diffuse, smooth surface bleb. It should not be a very thin cystic, or it should not be a very vascular, or it should not be an encapsulated bleb. It should be an ideal bleb is a diffuse, smooth surface bleb.
Thank you.
Can I comment on this, the anti-VEGF, Dr. Noman?
Yes, sir.
Anti-VEGF.
Yes.
Because I have done more than 100 cases with anti-VEGF Avastin. Just after trabeculectomy, I put anti-VEGF under the conjunctiva, and I have seen the results are very good, number one. Number two, whenever I do the bleb needling, I do not use MMC, rather I use the anti-VEGF. So that's why I get no complication, rather I get better result. So
yes.
It is not yet published, but I am trying to publish it.
Yes, I think
there are two schools of thoughts when we are talking about anti-metabolites or anti-VEGFs.
Yes.
Anti-metabolites, they work through the fibroblast, and anti-VEGFs, what we are using, basically the vascular endothelium is there. This vascular endothelium, they proliferate and cause vasodilatation. So by using anti-VEGF, this vasodilatation is decreased, and that's how we keep the success of this bleb. So there are two different mechanisms through which these two molecules are acting. So both these have independent role. I mean, one can be a substitute for another.
Yes. Yes, true.
Thank you for the Dr. Bipul.
Amit.
Hello.
Well,
we will come to you. Yes.
Noman, before Bipul, I had a question to Amit Parwal.
Yes.
That when you will remove the releasable suture, if you when you will remove it?
Okay. Ideally, what I do is I call my patient for a follow-up on 5th day. I see the patient first follow-up is on 1st day, and then I see on the 5th day again. So on 5th day, if the bleb is flat, I massage a bit. I call him again after 3 days. And if that time the bleb is still flat after doing the massage previously, then I release the releasable suture and institute the massage. So ideally by 10th day or 14th day, I remove my releasable sutures if needed. And if it is not needed, at the end of a month, if I feel that the IOP is achieved, the target IOP which I've aimed at is achieved, and now the bleb is functioning well, the internal ostomy is patent and is a nice bleb, then I trim off the releasable suture after 4 weeks.
Thank you. Thank you.
How much amount you are using the 5-FU in your? Do you use the 5-FU?
No, intraoperatively I use MMC 0.2 milligram per 0.1 ml, 0.02 milligram per 0.1 ml. If for a needling, when I'm doing a needling, I always use 5-FU. 5-FU, 5 milligram per ml, 5 milligram per 0.1 ml is the dose, and I inject it at the inferior part of the inferior fornix, or away from the bleb temporally or nasally. So basically, every alternate day, I call the patient for 5-FU injections. So I give the one injection, and then after next alternate day, I call and see how the bleb functioning, whether the vascularity has decreased or no. If it is not decreased much, I repeat the injection. So maximum 5 injections I give on an alternate day, and then on different locations.
Okay.
Okay, Dr. Bipul. There is a very interesting question. If you have in this subcontinent, a lot of glaucoma surgeons are doing the single suture trabeculectomy with triangular incision. So in that cases, when you think that it is going to be failed, in that case, what is your opinion about the, if it is a releasable suture, then if you release the suture, then that only one suture it will be released. Then what is your opinion about that? about the releasable suture in a single suture trabeculectomy, and also do you feel any complication immediate after sutural lysis? Do you have any experience of complications in the Islam table after sutural lysis?
Actually, in case of combined surgery, if you apply only single apical suture, there is no chance of there is no option to release the suture. Actually, in case of combined procedure, if you apply multiple suture, then you need to release the suture or you need to lysis the suture. But if you apply only single suture at the apex of the tubular tract, so there is no need to release the sutures, because I did every OT day, I need to do around 10 combined surgeries. So last 2 to 3 years, I did lot of cases, but I found good result with single suture trabeculectomy in at the triangular flap at the apex. So but if I confuse that there is a not such acid form, then I will apply 2 releasable suture at the side of the triangular flap. And Amit Parol sir also said that he applied releasable suture at the apex in case of trabeculectomy. Yes, this is another option. I also do this surgical technique also in the apex releasable suture.
Dr. Amit raised his hand. Yes.
Yes, he wants to say something. Amit Parwal.
I disagree with Dr. Bipul over here. He said if you put a single releasable suture, he has reservations that he won't release it. See, whether you put a single releasable, 2 releasable, or 1 apical and 2 releasable, it doesn't matter. Even if I'm using a single releasable suture, now if my blood is failing, I have to release the suture so that the aqueous filters out into the subconjunctival space and the filtration is maintained. If I get scared that there's only a single releasable suture and I don't remove it, then how I'm going to revive that blood which is failing? So even if you have a single releasable suture and release it, if it is needed, your AC won't collapse, because by 10 days already the fibrosis is occurring so much.
Yeah.
So if you release that suture, it is not going to cause any harm. So the take home message what I would like to say is, don't get scared if you have put a single releasable suture to release it. Because if it is indicated, you have to release the single suture also. And by releasing that suture, you're not going to have a shallow AC at all.
Okay.
Dr.
Dr.
Amit,
Nazrul.
I have
Nazrul will
many
add.
cases. Dr. Amit, I have many cases. I put the releasable sutures, but I have not released it. It remained for years. Doesn't have any problem. So
I think it will
actually,
not
if
be
the
a
pressure
problem.
is fine, if
That
the
means,
pressure
Dr.
is
Nazrul, we are
fine,
having good
you may
filtration.
not you may not release it even. Yes,
No,
that
I'm
is possible.
I'm talking about you have to release the single releasable suture if you have put only
If
a
the
single
pressure is
suture.
higher, of
If the
course, it is
pressure is high,
needed.
if the blood is
Yes,
failing,
yes.
you have to
Then you
tackle
can
it.
release it, because
Even
after
after
1 month,
releasing, it will not
there
be
is
harmful.
fibrosis and
Yeah.
there will not be AC shallow
It will.
anything.
I
That you
think
can release.
after
But
releases,
I'm afraid
I think
Dr.
sir.
Bipul has done that for the combined cases for many years, one single suture in combined cases. Still, I'm afraid to put only one suture,
I
because
do all my surgeries are single suture, whether it is combined or whether it is plain track.
My too, sir. I am
Yeah,
also doing the single suture.
yeah. I
Okay.
usually give 2 sutures because I feel I can sleep well. That is my
Okay, fine.
Yes.
as
So,
already he
Yes.
said that it is
All
the
the
person's
surgeons
choice.
should sleep
It
well.
is the surgeon's choice.
Acha,
sir,
So
Noman,
it is my
any
choice.
other
sir,
question, Noman?
sir,
Feel satisfied with one suture.
we have very interesting session now, sir. We
Yeah.
have for all panelists and for all speakers we have to discuss 2 things. One is Limbal based or Fornix based. Limbal based or Fornix based in the trabeculectomy. What's your opinion?
It is a
One by
personal
one. Professor
choice.
Nadim.
It is
Professor
a
Nadim.
personal choice.
Professor Nadim, please.
Fornix based.
Limbal based or Fornix based in the trabeculectomy. What is
So
your
unmute,
choice
Please,
and
please unmute. Please unmute.
Unmute, please.
one by one, just with single
Professor
with a very
Nadim.
single word.
Professor Nadim, please
Unmute,
unmute.
please unmute.
Professor
Yes.
Nadim.
Yeah, I usually prefer Fornix based and put 2 sutures on the side and sometimes 1 suture in the middle of the conjunctiva to secure the wound and should not have leaking from that side. I've been doing the limbal based for a very long time, but finally I feel that in my own hands, this Fornix based is safer.
Thank you. Dr. Amit.
Yeah,
Dr.
same.
Amit?
I do only Fornix based, Limbus based. Sorry,
Oh.
I do only Fornix based. I don't do Limbus based at all.
Okay, fine.
Okay, okay, thank you. Professor Nazrul.
Actually,
Nazrul?
a few years before, I used to do for the children, for the infantile glaucoma, I used to use the limbal based only. But even recently, I have not doing the limbal based. In all cases, adult and children, I do Fornix based, and I feel more easy and relaxed with this technique. And actually, it is a technique how you learned it, and you have shown that study says there is no difference of surgery success. What method you are doing? So I think the way you are relaxable, you are easy, you can do that is your way. That is the way, and I do always be Fornix based.
Professor Mizan.
I always prefer Fornix based. I have not done any single case limbal based.
Fornix based
So
is
Fornix
winner.
based.
Okay.
Yes.
Yeah, that is the
Dr.
winner.
Bipul.
I do
Dr.
only
Bipul?
Fornix based.
Okay, fine.
Yes.
I have a question to
using...
Noman. Noman,
Yes, sir.
I have a question to you, as your presentation have been given, but if we don't ask you any question, it will not be a good one. You have told about the glaucoma drainage tube. Do you use the glaucoma drainage tube in congenital glaucoma or not?
Yes, I have some experience doing congenital glaucoma drainage tube. I used to use the Ahmed valve implant. I implanted almost 20 cases in a congenital glaucoma, and it really works good. But the most important thing is, the congenital glaucoma, they are very poor. They cannot afford that tube. So we got some tube from the with some donation from the Orbis International, and with that we used to implant some tubes in the congenital glaucoma. And I have also a lot of questions in the audience side, but I cannot ask myself even. So I have also one comment about the Fornix based or Limbal based. I'm also doing the Fornix based, but when I started the congenital glaucoma surgery, I used to do the Limbal based incision. But still, now I am doing the Fornix based, and very interesting. I started with 3 sutures. Even now, I am using the 1 sutures in the combined trabeculectomy and trabeculotomy. And I think it's working good. And I'm trying to publish one study about that. Thank you.
My comment, Professor Sharfuddin, in case of congenital glaucoma, I do not prefer the valve first. I always try to do the trab and trab, trabeculotomy, trabeculectomy, or combined. If it fails, then I go for the pediatric implant for the children.
Yes, sir. I have also done it in the failed cases, because the congenital glaucoma, the valve is implanted in the failed case.
Primarily, yes, it in failed case. Okay,
yes, failed case. I have also done it in the failed cases.
Failed case.
Okay, fine. Now we can go to our panelists. Comments from the panelists. Any other comments? Noman, we can go to our panelists first.
We have
any other question?
Sir, with your permission, another one very single, very short answer you will give everyone, because it's a very common question. Calipunch or direct trabeculotomy? What are you using, Professor Nadeem? Calipunch or direct trabeculotomy?
Direct trabeculectomy.
Amit Parvel.
I use the Calipunch.
Calipunch. Professor Nazrul?
Most of the time I use Calipunch, but there is 2 indications. One is if the AC is deeper, like myopia or aphakia, pseudophakia, then I try to do trabeculectomy excision. But when there is AC shallow, especially in the angle closure glaucoma cases, I always use Calipunch. That is my usual practice.
Okay, thank you. Professor Mijan.
I'm not using that Calipunch, just excision of the iris with anesthesia.
Bipul, Dr. Bipul.
Direct trabeculotomy.
Direct.
Calipunch. Calipunch? Okay. I think I am also using Calipunch, and both according to situations. So I think we have a lot of questions. Actually, we have time constraint. We have already passed 2 hours, 14 minutes. It's a huge. Thank you. I think, do you have any comments? One by one, you can do comments.
I think
yes, Professor Nazrul.
First of all, I like to thank the BORF the President, Professor Sharfuddin Ahmed, Member Secretary, Dr. Shams Muhammad Noman, for having the opportunity here, all of us. And definitely our friend, Professor Nadeem Bhatt, Dr. Amit, also welcome to Bangladesh webinar. And really, they spoke very nicely. Their presentation was really useful for the residents, mostly. All the three presentations on trabeculectomy by Dr. Amit, by Professor Nadeem, and Dr. Bipul, all of them was very useful. I think it has told every part of trabeculectomy. So really, it has been useful for all of us, especially for the residents. I like to thank all of them, and definitely our colleagues, especially Dr. Bipul, Dr. Shams Noman, and Dr. Amit, they're comparatively younger colleague, and they have done very nice, and they have shown their efficiency. They have done very good. We'd like to congratulate all of them, and definitely Professor Nadeem, thank you very much, and we hope you will come again. And along with me, Professor Mizan, my colleague, my brother, he is with us. Definitely, we are very glad to have you here. I hope that this webinar has been very useful for all of us. Thank you very much. Thank you very much.
Okay. Professor Mizan.
Thank you, Mr. Chairman, Professor MD Sharfuddin Ahmed. I think it's a great pleasure to us that we, the regional, SARC regional ophthalmologists, renowned glaucoma specialists, and other renowned ophthalmologists, we joined virtually and we discussed about the glaucoma. And every topics, every presentation was very nice. And actually, it's a global challenge to manage the glaucoma. And today, in this region, from screening to step-by-step trap, everything, complications and valve, everything is discussed nicely. One thing is that actually trabeculectomy is a very gold standard and traditional outflow surgery, but it is very unpredictable. On that respect, Professor Nadeem and Dr. Amit and Dr. Shams Muhammad Naman and Dr. Bipul, they have presented very nicely, and it will be very good and very benefit for our resident and also for us. So I must thank everybody on behalf of Glaucoma Society, being a president, and our past president, Professor M. Nazrul Islam, and advisor, he is also here. And especially thanks to Professor Abha Madam, Professor Muhammad Sharfuddin Ahmed, and Dr. Shams Muhammad Naman. He is pioneer for this webinar arrangement. And I must thanks to all foreign speakers on behalf of Bangladesh and Bangladesh Glaucoma Society. Thanks to all.
I forgot to say the name of Professor Sumon Thapa. I like to, because I cannot see him. He is not in the video. So I could not see him. Professor Thapa, thank you so much, because of your amazing lecture. We learned really.
Thank you so much.
In this region,
Thank you.
in Bangladesh, India, Nepal, you are one of the pioneer in the screening of glaucoma. Thank you very much for being with us.
It is the digital revolution.
Thank you.
Digital revolution, and Sumon Thapa, you have inspired all the countries of SARC region that they should also come forward for screening of glaucoma as early as possible.
We like to listen to a song later on.
We can hear from Professor Nadeem Bhatt from as a panelist, your comment.
I think it's a wonderful activity, and glaucoma is such an interesting topic that you can arrange maybe several webinars and keep on discussing for hours and hours, and people will never be bored. Whenever we have panel discussions in our own country and these kind of seminars, face-to-face seminars or webinars, people are sitting there for hours to listen to the talks and discuss it and question and ask questions. So this activity was very, very nice, wonderful, and it has been arranged very nicely by Shamsuddin Naman. And I'm very grateful to all the panelists and all the speakers for their valuable time, for supporting this webinar, and especially Professor Awa, Professor Sharfuddin, and all my colleagues from Nepal, from Bangladesh, from India, and from Pakistan. So thank you so much for giving me the opportunity of participating in this seminar.
Okay, thank you. Noman. Just now, I will give the thanks and I will close. One thing, that for the invitation of Bangladesh Ophthalmic Research Forum, as well as Bangladesh Ophthalmological Society, as all the panelists, all the speakers from our region, that is India, Pakistan, Nepal, all the countries, including Bangladesh, you are today's Bangladesh webinar or SARC webinar on glaucoma. Thank you very much for giving us a lot of time. And today, I think Professor Nadim, Amit Parwal, Shumon Thapa, Dr. Bipul, and Dr. Noman, you have nicely presented and you spoke in such a way that it is not only for the resident, even other ophthalmologists who are not working on glaucoma, they will also learn a lot. And it will be very much helpful, as because the people, if it is more than 50 years, if they have any family history, these type of people should come to ophthalmologist and they should ask whether, sir, I have glaucoma or not, I have ocular intraocular pressure, can you measure it? If the person can talk and if they desire this type of asking question, I hope there will be screening of the glaucoma will be increased, and in our country we should come forward for screening of glaucoma after the age of 40. Everyone should go for their screening of glaucoma. I think this type of webinar, there are a lot of questions whether the phaco will be in same port, combined operation, or will be in separate. It depends on the different surgeons, maybe in the same port, maybe in the different ports, phaco and trap. But I think today is within the limited time, that is 2.5 hours. Probably we have already crossed. In future, on glaucoma and other interesting subjects, we will have other SARC webinar where I already mentioned that Professor Rajbardhan Azad will come. I have already talked to Noman that he will take time from him, and we will go for another SARC webinar in the month of August. And I hope Professor Nozrul, Professor Mizan, Professor Nadim as a panelist, you are here. We are very grateful to you. And in future, if any subspecialty, if you can make any sorts of webinar, I hope as a president of Ophthalmological Society of Bangladesh, I am always with you. I will give all the support along with the international speakers. I thank Professor Abha Hussain, our president APAO elect, who gave us time for long period. And in future, I hope she will be with us, Professor Nadim Bhatt, Professor Nozrul, Professor Mizan, Professor Amit Parwal, Dr. Professor Shumon Thapa, and Dr. Bipul Sarkar, and not the last, he is the main man, Professor Dr. Shams Mohammad Noman, who organized it and given us a lot of time. I thank Aristovision, who has given us our support for this webinar. And in future, we all will be together after COVID-19 face-to-face. We want to see you in Kuala Lumpur, probably in the next year, 2020, in August. We'll be there and we will see face-to-face. And before that, I will pray to Almighty that we all should be free from COVID-19 and we'll be in good health. And I hope good wishes and more life expectancy of all of us. Thank you very much. Professor Nozrul, do you like to have any point?
With your permission,
Yes.
I want to invite all of you in the
Yes.
international webinar by Bangladesh Glaucoma Society on 22nd August, where Professor Aik Ahmed from Canada will join, and also Professor Tanuj Dada and Professor Selvin Singh from Singapore.
Yes.
They will be in the webinar. So all of you are invited to that webinar on 22nd August.
Thank you.
I hope
Thank
you will give the link to all.
Yes.
Thank you, Professor Nozrul. Thank you. And I have also another, I want to tell another thing from the permission of Professor Sharfuddin Ahmed. We are planning to arrange another academic webinar. How do we manage the postgraduate exam and education in the COVID period? We have also discussed with the All India Ophthalmological Society. I have also discussed with Professor Nadim Hafiz and Professor Shumon Thapa. He is also leading the Nepal education. So we will arrange another educational program from the Ophthalmological Society of Bangladesh. I will communicate with you later on. Thank you.
Okay.
Thank
Okay,
you.
Thank
Professor
you.
Nadim
Thank
Bhatt.
you.
Thank you
Thank you.
all.
All, thank
Thanks
you very
to
much.
Thank you all.
Nice
Pakistan,
Thank you.
India,
Thank you very
Nepal,
much.
Bangladesh. Thank you very
Thank you,
much.
Professor
Okay.
Shuman.
Good
One
luck.
comment.
Professor
Thank
Shuman.
you.
Okay, thank
Thank
One
you.
you.
comment.
Thank you.
Very
Professor
much.
Shuman.
All of you are
Bye.
invited
Samit
on
Parwar.
Friday. All of you are invited on Friday evening 7 o'clock for the ISM 6 webinar.
Yes.
And MP chapter installation is there. And
Yes.
Okay.
Dr. Miznu Rahman is our invited guest faculty from overseas. So
Thank you.
Inshallah, I'll be
it will be
there.
a pleasure. He will have the link and I'll send the link to Shams.
Okay.
So
Okay,
that
you
he
Yes.
will,
can forward it
Shams
over
will
there.
Okay.
give the link to all and
Yeah.
we will
Okay.
join. Thank you.
Okay.
And we
Thank
should
you.
work
Thank you.
forward
Thank you
for
very
the
much.
SARC Glaucoma
Thank
Association
you.
also.
Yes.
Yes.
Dr.
And
Nadim is already here as the
Okay.
president
Thank
of
you.
SARC.
Thank you
Thank
very
Okay.
much. We will
Okay,
see
just
you
Thank
again.
you.
send me
Bye.
the link. Okay.
Okay.
Professor
Goodbye.
Mizan, can you please stay for a while?
Okay.
Okay.
Okay, we can leave now.
Okay. Okay,
And
sir.
you can
Yeah.
talk with, yeah. Thank you very much. Khuda
Thank you.
Hafiz.
Thank you.
Thank you.
Thank
Thank you.
you.
Assalamu
Thank you.
alaikum.
Thank
Thank
you.
you very much.
Thank
Thank
you.
you.
Thank you, Professor Nazrul sir. Thank you.
Thank you
Thank
very
you, sir. Sharafuddin sir. Thank you. Mijan bhai.